Sorry, I was just wondering if you were going to do any primary data collection from patients and consumers when you're looking at how those groupings are clustered based on the analysis you've done with the claims.
So for the body of work that has been funded, the answer is no. Although we're hoping to incorporate the OASIS data set, which is survey-based with some of the Medicare claims data. And hopefully that gives a little bit of an insight into your question.
Other questions? If you can come to the mic and identify yourself. We've got folks on the webcast, so.
Thank you for that. Thank you for an exciting beginning. I'm Pam Hines, and I'm from Children's National Health System, and I'm wondering if your data will include children with complex needs.
So as for us, the getting data, studying that group is relatively hard, in the sense that when you're comparing, so you need Medicaid data, and so when you're comparing across the different states, it's different states report out data very differently. So trying to find a commonly distributed variables across the data sets is difficult, but yes, we will. With we're planning on having at least 6 states that have the most granular data as we can get to study the medically complex children.
How about time for 1 or 2 more questions? These are great to understand the project. Any other questions for the partners here at the outset? If you could come to the mic, that would be great. Thank you.
Question for Jose. Since it's a question of data, what kind of data we are talking about?
So we most of our analysis, or all of our analysis, is claims-based. So obviously there's a lot of limitations with claims-based data. We will use the most updated claims-based available for each group of patients. And so for the duals, we're using MMLeads data, which is limited up to 2010, 2011, hopefully coming soon. For the Medicare data, it's obviously CMS-based, and then we'll use up to the most recent year, which is 2013. And then for the Medicaid data and commercially available data, we're going to try to use SID data, so the state and patient databases. In Massachusetts, we have, in a few other states, there's the APCD data, the all-payer claims data. We have access to those. And then we have also various states, Medicaid-specific data for other states.
All right, last 2 questions here.
Hi, I'm Deborah Ness with the National Partnership for Women and Families. I'm excited about the conversation we're going to have today. But I want to go back to the question that Allison asked. Because as we think about these issues in the consumer community, we think there's sort of a 3-part flow to the framework that we need to use. And first is really starting with, what do the patients and family members involved here really think they need and want, understanding it from their perspective. And secondly, translating that into what other criteria, characteristics, processes, structures of successful approaches or models to delivering on that, as well as providing the better quality outcomes and cost reductions. And then the final is the metrics that you use, and ensuring that in the metrics you use to evaluate those models, you're looking at both the impact on the patients and their experience, as well as the impact on quality, clinical quality, and resource use. So I know that starting with the patient part wasn't part of this design, But there is a body out there of work that the consumer advocacy and patient community have put together, and it wouldn't be that hard to look at how that body of work comports with the structure and criteria that you've identified as important, and seeing where we have overlap and where there might be some additional factors to consider.
Could I know Catherine fill us in, but could I just respond from the perspective of the policy side of the equation? The quantitative analysis and looking at the micro data sets that Jose talked about, that's the first part of this project as I envision it. As we move down the project to get down to the BPC end of it, when we get to policy, I don't think there's any question but that Catherine and the project that we're working on will seek and input into the process a qualitative information that is available out there. I don't think there's any question that will not happen, particularly as we go down the line in using the data and refining the data and then inputting your input into this process. Catherine, am I off?
And that is one issue that has really come up as we've started working with stakeholders. And that is what really pushed us to the issue of sort of rethinking how healthcare is delivered. And it seems like a daunting task right now. But the first step, what really brought us to this idea, was that in so many states that are doing well with dual eligible individuals, they started with the patient. They go into the patient's home, they talk to the parent, particularly for children with disabilities, children with behavioral health. And the benefits that are provided under the Medicaid program typically and Medicare don't align with what folks need, and quite frequently are much less expensive and certainly could save inpatient hospitalization costs, one would think. So that is really why we're looking at building from the ground up instead of, well, we'll be doing both. But.
So just to close this, we're an advocacy organization, so we're advocating for a paradigm shift. And one of the things that you said is starting with the patient first. We have this mindset in healthcare where we think we can build it. We know the great ways. We're going to figure out the best way to build it, and then they'll come, as opposed to we'll build it with them, and then they'll already be there with us. So I think we need to always constantly be checking ourselves, because we do have a major paradigm shift, and we tend to bring the patient and consumer voice in the middle or after the fact, as opposed to at the beginning as the starting point.
Last question, we'll have a brief, and then we'll...
This is Dr. Amita Rastogi from HCI3. We are a nonprofit organization and working with data for many years now. And just a quick question for Jose. So as you're working with claims data, are you going to be pulling in pharmacy and lab data to enhance your models?
Can I just say yes? Yes, yeah. We will. We have Part D data for the Medicare claims data. And with that, there's lab data, imaging, tests, things like that. Yes.
And then I will take the moderator's prerogative and answer to the previous question around, we have vital signs. I mean, there's a report from this consortium that gave us 15 domains to think about core measures, which if you look at those 15 domains they cover, they are not healthcare-centric or medical-centric. They give you a lot of room to really think about, from patient engagement, community engagement, evidence-based care, unintended pregnancy. I mean, they give us a wide range of opportunities to think about measurement and standardization of measurement. So I think your point is well taken, and the good news is there's been work done, complementary work. So why don't we thank our partners